Hello everyone and welcome to my YouTube channel. So today I'll be discussing about supraventricular tachycardia. So SVTs originate at or above the atrioventricular node, that is above the bundle of hairs. So the conduction below the AV node is normal, that is the ventricles conduction will be normal. So SVTs have narrow QRS complex. SVTs occur mostly by two mechanisms, re-entry and automaticity. So the re-entrant arrhythmias occur when the electrical impulse recurrently travels in a tight circle within the heart. However, automaticity occurs when cardiac cells start firing action potential spontaneously. So this is a rhythm of supraventricular tachycardia. You can see these are very narrow QRS complexes and you cannot distinguish the P wave because it is buried in the QRS complex. Now I will discuss about two common causes of supraventricular tachycardia. One is atrioventricular nodal reentrant tachycardia, which will occur due to a re-entry circuit, and the second one is atrioventricular reciprocating tachycardia, which is due to an accessory pathway. So AV and RT is the most common cause of supraventricular tachycardia and it is characterized by a re-entry circuit within the AV node. It depolarizes the atrium and ventricles nearly simultaneously, and it has two pathways. The inferior one is slow pathway for antegrade conduction from AV node to the ventricles. However, the superior pathway is the fast pathway for retrograde conduction, that is re-entering the atria via the AV node. These two pathways have electrophysiological properties similar to AV nodes. The ECG will show narrow complex tachycardia, that is tachycardia with normal QRS complexes. There will be no discernible P waves, that is P waves are buried within the QRS complexes because circuit is short and conduction is rapid. So this picture is showing AV and RT with a re-entry circuit in the AV node. So the second one is atrioventricular reciprocating tachycardia, and it is characterized by an accessory pathway between the atrium and the ventricles that causes a re-entry circuit. The accessory pathway has electrophysiological properties similar to ventricular myocardium, and this type of SVT is seen in Wolff-Parkinson-White syndrome. I have discussed Wolff-Parkinson-White syndrome in another YouTube video, you can go and check out. So the ECG in AVRT will show narrow complex tachycardia. P waves may or may not be discernible. So this is the AVRT with accessory pathway between the atrium and the ventricle, and it will cause re-entry circuit. So the above one is the normal heart, which is showing a normal conduction pathway. However, on the bottom towards the right side, there's AV and RT, which is showing a re-entry circuit within the AV node, and on the AVRT side there is a re-entry circuit but between atrium and ventricle, which is an accessory pathway. This is another picture of AVRT and AV and RT. The treatment is not always necessary. However, an acute episode in hemodynamically unstable patient can be treated with immediate DC cardioversion, and the acute episode in hemodynamically stable patient will require the following treatment. So the best initial step is vagal maneuver, either carotid massage or Valsalva maneuver, ice immersion, anything, but it's the best initial step. If vagal maneuvers fail, then drug of choice is IV adenosine 3 to 12 milligram. If adenosine isn't effective, then IV beta blockers, example metoprolol, can be given, or IV calcium channel blocker like diltiazem or verapamil can be used. Recurrent SVT requires catheter ablation, which is the most effective therapy. So we will ablate the accessory pathway or recurrent re-entry circuits. Alternative options include prophylaxis with beta blocker, calcium channel blocker, or flecainide. So that's the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you so much.